So I just thought to little tweak the topic to understand. In fact, I put this question forward and I will try to answer. We know in 2008 advanced trial, which was gliclazide MR-based intensive versus conventional arm. And now we have Carolina, where glimepiride was compared to linagliptin. So always in clinician mind question comes that, well, glimepiride is as good as linagliptin from Carolina. What about gliclazide, which shown benefit at least in the microvascular outcome in nephropathy in the advanced trial. So I thought that I will take you through the advance from 2008 to right now and how to choose between these two, glimepiride and gliclazide. Of course, we are not recommending glibenclamide for that matter. Glipizide is hardly used nowadays, perhaps maybe CKD settings when one would like to use SU, the glipizide still remains, but that's the minuscule percentage of patient. So finally, we bumped down to two as sulfonylurea, which is gliclazide and glimepiride. So the story starts way back to 2008. So in your left-hand side is the original advanced trial presented and published simultaneously with the ACCORD trial in NEGM in 2008. And then traditionally, all these intensive trial also has got a follow-up study starting from UKPDS post-trial monitoring data of next 10 years to advance on, then accordion, then BADT on. So advance also had follow-up data, so that is observational follow-up of a randomized control trial, advance, which was primarily best with gliclazide. The difference between UKPDS advance, BADT, and ACCORD was that in advance, exclusively the gliclazide MR was studied in the intensive arm compared to the conventional arm. Here is the result. It's a BG slide. I will show you the data from that. What happens in this particular trial, that the primary objective of the study in advance was to look for the composite of both macro and microvascular complication. The macrovascular complications was exactly 3P mesh of the current trial, which you see in the CB outcome trial. And the microvascular combination was nephropathy or retinopathy. And trial has a primary outcome that we will study both the major macro, means 3P mesh, and major micro, means nephropathy and retinopathy. And there was a 10% reduction in the composite of both macro and microvascular endpoint in the advanced trial. Remember, we didn't have any benefit in the ACCORD intensive arm. We didn't have any benefit in the intensive arm of BADT. Even in UKPDS, we had a minuscule benefit during the active trial period in the nephropathy arm and the cataract reduction. Only the MI reduction benefit happened in the 10 years observational follow-up data of UKPDS. So the advance in that way, when you compare UKPDS, ACCORD, and BADT, was the first trial to suggest that intensive blood glucose lowering might reduce the composite of both macro and micro. Although this data was primarily skewed by benefit from the microvascular endpoint, exactly no benefit seen in the macrovascular endpoint even in the advanced trial. And the primary, this benefit is emerging from the nephropathy benefit. There was 21% reduction in the progression of diabetic nephropathy in the gliclazide-based intensive arm in advanced trial compared to the usual arm. So that's the data in the advanced way back in 2018. There is one caveat in this trial, and many purists might say that even in the advanced trial, 57% of patients in the usual arm were also receiving sulfonylurea. So this is one way to say then what is the utility of that trial? Means 57% of patients in the advanced trial were receiving other sulfonylurea other than gliclazide. I would critically say that in one way this is good, that this indirectly compares that gliclazide intensive arm showed a better reduction, even there was 57% patient in usual arm receiving other sulfonylurea that includes glibenclamide and glimepiride. The controversies with sulfonylurea dates back to 1969, and you won't find this paper right now anywhere because diabetes, that publication is no longer on the web, so hardly you get this slide. I just copied it very recently. So UGDP trial suggested that tolbutamide increases cardiovascular death. This is way back in 1969. You can see there was 26 event in tolbutamide arm and 10 in the placebo arm. No difference in all-cause mortality, but there was increase in cardiovascular death. This trial subsequently led, this PI for all the sulfonylurea to say that the sulfonylurea increases cardiovascular death. Even if today, if you open any sulfonylurea's PI, whether it is glimepiride or even gliclazide, you find that it is written that sulfonylurea increases cardiovascular death. So since 1969, there was a huge controversy whether sulfonylurea is a cardiovascular safe drug. So I just find out, so what are those trials since 1969 from UGDP to as of now happened with sulfonylurea and what happened in those trials. Remember, barring the last two trials, Tosca-IT and Carolina, these were not a dedicated sulfonylurea trial, but in these trials, other than Tosca-IT and Carolina, also used sulfonylurea and compared with active comparator. The ADOPT and RECORD were not powered to see the cardiovascular event, so incidental cardiovascular reporting was given in ADOPT and RECORD study where the glibenclamide was compared to rosiglitazone and metformin. As you know, in UK-PDS, sulfonylurea was compared to insulin in UK-PDS 33, and there was no signal in terms of any cardiovascular mortality or increase in MI. So the UK-PDS was the first trial to refute that sulfonylurea caused any harm like UGDP study with tolbutamide was done. Then in ADOPT in 2006, as I said, it's not powered, but then there was no difference between glibenclamide and rosiglitazone. Advanced, this is what we talked, there was 10% reduction in the composite of both macro and micro, primarily derived from 21% reduction in diabetic nephropathy in gliclazide MR-based intensive arm. The RECORD again compared glibenclamide to rosi, no difference. But difference between ADOPT and RECORD was ADOPT was on the background of metformin and ADOPT was, without background metformin. So naturally, we were all looking for the two trial, Tosca-IT and Carolina. I will take you a little detail in this two trial because that was what we looked for in past couple of decades, in fact, since 1969. When it comes to observational studies, although in one hand RCT didn't show any signals in respect to cardiovascular risk with sulfonylurea, the meta-analysis of observational studies, so I'm not taking all observational studies, it could be more than 200. So I just included only the meta-analysis of those observational studies which studied sulfonylurea and reported for CB endpoint. So starting from 2006 to 2017, you see there is a huge controversy. Majority of those observational meta-analysis did point it out that sulfonylurea has an increase in cardiovascular risk and mortality, at least in many of those meta-analysis. However, there are basic issues with observational studies, and this is one of the paper from the last one, Azule's 2017 data in diabetes care. And they said that if you see the previous meta-analysis of observational trial, they are basically flawed because of their inherent problem in taking the data from observational studies. And so any conclusion with regards to CB safety of sulfonylurea from observational studies is majorly flawed. The flaw could be various, as you can see under 3 headings. They defined different studies and suggested that we don't have any robust data which suggests that sulfonylurea causes cardiovascular harm. Well, also to point out, even in those meta-analysis of observational studies, there were differential outcomes among the sulfonylurea class, and that's the area of interest one should look for. So I would quote 2 meta-analyses where different sulfonylurea were compared with each other and reference to either metformin or glibenclamide as a reference point. So this first of this meta-analysis, as you can see, this is European data and extensive number of patients published in European Heart Journal. And when they looked different sulfonylurea keeping metformin as a reference, one thing pretty clear came was that at least one sulfonylurea which has not shown any signals of increase in cardiovascular risk, whether patient has a baseline heart disease or not, is the gliclazide. And that was surprising. And you can appreciate here in this list, there is glibenclamide, glipizide, ripaglinide, the older so-called tolbutamide of UGDP, and glimepiride. But when you compare with the metformin, the one sulfonylurea which stands out different from this meta-analysis was the gliclazide. That's pretty clear from this observational data. The second observational studies again similarly looked, and then they compared different sulfonylurea, keeping glibenclamide as a reference. And again you can see the one molecule which stands out different is again gliclazide, and it didn't happen as a chance. You have got two big meta-analyses suggesting that gliclazide seems to have a different outcome compared with their counterpart. Maybe glimepiride is very close to gliclazide as far as these mortality is concerned, but then gliclazide stands out different. So people started thinking why there is a difference with gliclazide as far as different sulfonylurea is concerned. So I had the opportunity to do a systematic reviews and meta-analysis, and you can see this paper in 2016 after those two differential outcome. And this is busy slide, let's not go into that. Only point out I would like to do, there is a one renal endpoint study, and perhaps the second study head-to-head of glimepiride versus gliclazide, or perhaps first study in fact which looked for a renal outcome as an endpoint. Surprising to see in the renal outcome study, the gliclazide outright beat glimepiride, especially in elderly population. You can see there was a 80% reduction, exactly 79% reduction in the renal outcome in the gliclazide arm compared to glimepiride. So basically, this reviews suggest that when you see all these three sulfonylurea or four sulfonylurea together, the best mortality outcome data among the sulfonylurea lies with gliclazide, immediately closely followed by glimepiride. Glibenclamide has a worst outcome data, and I would not recommend you to use. In fact, ADA 5 years back suggested that let's throw glibenclamide into dustbin. The all wrong data, perhaps sulfonylurea has emerged from the older sulfonylurea, starting from tolbutamide, chlorpropamide, and to glibenclamide. So now this is a high time that you should select this first two sulfonylurea, which is gliclazide and glimepiride. Now when it comes to the head-to-head study, we have only one head-to-head study, which is double-blind randomized controlled trial conducted between gliclazide and glimepiride head-on. And this is called GUIDE, 15 years old study. There is no study henceforth done in last 15 years. So this is the only reference to understand which molecule stands out as far as hypoglycemia is concerned. You can see in this double-blind randomized controlled trial, a 26 weeks trial, shows no difference in HbA1c between two sulfonylurea, but there was a 50% less hypoglycemia in gliclazide MR arm compared to glimepiride. So one thing is pretty clear. When it comes to hypoglycemia, gliclazide MR seems to beat glimepiride outrightly. Is there any evidence? We had the opportunity to look for the study which has to be the best as far as hypoglycemia is concerned, doing a sulfonylurea trial during Ramadan. So I did a review of all the RCT done with sulfonylurea during Ramadan and looked for a hypoglycemia outcome with sulfonylurea. Here you can see three studies where different sulfonylurea was compared with DPP-4 inhibitor. And we had a feeling that DPP-4 inhibitor caused less hypoglycemia in their head-to-head trial, and also Carolina suggested, which I will come little later. But surprisingly, during the Ramadan, and that's during RCT, you can see there was a higher hypoglycemia with sulfonylurea, but when you differentiate sulfonylurea class individually into glimepiride, gliclazide, and glibenclamide, the data seems pretty interesting. And gliclazide, again, you can see here during Ramadan, found to have a similar hypoglycemia like DPP-4 inhibitor. You can see in two trials it was sitagliptin, in one trial it was vildagliptin, and gliclazide seems to have pretty similar hypoglycemia percentage during Ramadan, and this is a randomized control trial. So there are two evidences, one from direct head-to-head study, and second from the Ramadan hypoglycemia studies, all data hinting that there is a potential for glycoside to cause less hypoglycemia, and there is a reason behind that. I will not go into, because of their mechanism of action on different sulfonylurea receptor, but I will not go into because of paucity of time here. But the data did suggest that hypoglycemia is lesser with glycoside, in particular MR, compared to the glimepiride as far as hypo is concerned. And no wonder, if you see the different guidelines in the world, they have changed, choosing among the even sulfonylurea. The NICE UK first in 2008 suggested that among the SU, glycoside should be the first among the SUs. The Dutch guidelines in 2013 put glycoside after metformin. Even WHO essential list of medication which had glibenclamide earlier prior to 2013 replaced glibenclamide to glycoside in their essential list of medications. And recently in 2015, the Canadian guideline chosen glycoside as a preferred SUs. And that's what I wrote in this particular paper, whether glycoside is different from sulfonylurea. And adding glibenclamide into the entire basket of sulfonylurea class perhaps is making all the signals which we have seen so far. So since the publication of ADVANCE in 2008, we had no studies of SUs with regards to CB outcome until 2017. And we patiently waited for these two more trial, which was under progress, was Tosca-IT and Carolina. So I will quickly take you through. The Tosca-IT was the Italian trial where pioglitazone was compared head-on to sulfonylurea as an add-on to metformin. This trial was stopped because of futility, because there was no difference between pioglitazone and sulfonylurea. We expected that pioglitazone should beat sulfonylurea, considering pioglitazone has pleomorphic mechanism of action. And in one of the two soft endpoint trials like Periscope and Chicago, the pioglitazone has already beaten glimepiride head-on, at least in reducing carotid intima media thickness, or in coronary intravascular ultrasound in Chicago. So we had a feeling that pioglitazone should beat sulfonylurea, but in Tosca-IT, there was no difference between pioglitazone and sulfonylurea. So it's a 5-year trial, and Dr. Fonseca has a commentary, in the Lancet. And there was no benefit with pioglitazone compared to sulfonylurea. I will look it, just opposite, and I would say that sulfonylurea was as good as pioglitazone, and there was no signals of cardiovascular risk with sulfonylurea compared to pioglitazone. In fact, if you see this trial, there was high increase in heart failure hospitalization with pioglitazone compared to sulfonylurea, and I will compare it little later. Then came the Carolina. Carolina was a trial, it's an active comparator trial. 42% had established cardiovascular disease. These are young patients. You can see even 9% patients were treatment naive. And this trial was conducted for a median duration of 6.3 years and compared glimepiride head-on, and there was no difference in CB outcome between linagliptin and glimepiride. That's the greatest news for glimepiride, I would say, rather than the linagliptin. And this is the data. Remember, Carolina is not yet published, so I need to look into entire data presented at ATA. And you can see in anywhere, there was no benefit in linagliptin compared to glimepiride. In fact, if you see the heart failure outcome, somewhere it was surprising that there was some signal noise coming out of the linagliptin as far as heart failure is concerned, but not with glimepiride. But where the linagliptin beats glimepiride outrightly was the hypoglycemia. You can see whether it's any hypoglycemia, moderate to severe or severe hypoglycemia, there was statistically significant higher hypoglycemia with glimepiride as it expected to be in the Carolina trial. However, if you see the hospitalization requiring hypoglycemia, it wasn't that high even with the glimepiride compared to the linagliptin. So if I have to summarize Carolina, what I understood through the Carolina, although remember it has not yet been published, both lina and glimepiride were CB neutral and well tolerated. Glimepiride shows similar durability of glucose control. And this story now ends up by saying that sulfonylurea has got less durability. At least in Carolina, there was no difference in glucose control up to the trial ended at median 6.3 years. There was a similar glucose reduction, and that questions durability, whatever was talked prior with sulfonylurea. Although there was a threefold higher hypoglycemia, as I talked about with glimepiride, more so during the first year. Remember, the average dose used in Carolina was 3 milligram of glimepiride. But patients requiring hospitalization was only 0.9% higher with glimepiride. Also need to remember, in other hand, linagliptin has 0.6% higher patients who were admitted with heart failure hospitalization. So the commentator actually, concluded that if you are using glimepiride, there is a 25 more hypoglycemia, but if you are using linagliptin, you have got 20 more heart failure hospitalization. Choice is yours between choosing between these two drugs. Now, when you took all these three trials together, so because I'm just running short of time, I will quickly have compared here ADVANCE, the first sulfonylurea-based trial, then TOSCA-80, used 50% glipizide, 8% glimepiride, and 2% glibenclamide, and Carolina. So here, this is a comparative data. Looks pretty similar as far as the duration is concerned or baseline HbA1c is concerned. But when it comes to the outcome, that only trial with sulfonylurea which shown any benefit was the ADVANCE trial with gliclazide MR-based intensive arm. Whether it's a primary outcome, it's a microvascular event, especially nephropathy, you see benefit in the ADVANCE with gliclazide. In TOSCA-80, there was a heart failure signals with the pioglitazone compared to sulfonylurea, and Carolina also had somewhere noise of heart failure, which we need to look into little detail once the entire data is presented. So, ladies and gentlemen, to present advancing and ADVANCE to Carolina, what I thought should be my take on that glimepiride shown CV neutrality in Carolina. So all controversy related to cardiovascular safety within SU class have been put to the rest. This trial also showed similar durability up to 6.3 years. That's the great news, that we thought that sulfonylurea lose durability. The best example was glibenclamide versus rosiglitazone and ADOPT and RECORD. But remember, the glimepiride and gliclazide is different from glibenclamide. There are many studies which suggested that glibenclamide has got less durability, more secondary OHA failure compared to glimepiride or gliclazide. This may be the reason. However, there was a significant increase in hypoglycemia that needs serious attention and pharmacovigilance. The only double-blind randomized controlled trial which compared glimepiride head-on to gliclazide was the GUIDE and shown 50% less hypoglycemia with gliclazide MR. Two meta-analysis of observational studies showed the gliclazide has got best CV mortality outcome data amongst the sulfonylurea class, and the only ADVANCE trial suggested gliclazide benefit in the nephropathy protection. So when you have to choose between gliclazide and now glimepiride after Carolina, both are CV neutral drug, but former cause less hypoglycemia. That's my take. Thank you very much for your patience listening.